Please join me in welcoming Cait DesRoches.
So thank you for the invitation to talk today. I'm going to talk a little bit about the organization that I work for, OpenNotes, and I'm only going to talk, I think, for about 15-ish minutes to just leave plenty of time for questions. And I'd like to start off by saying that I have no actual or potential conflicts of interest related to OpenNotes. I want to be really clear, we're not a software company. We don't sell anything. We don't have a platform. We don't host notes on a server. We are focused on the idea of transparency and on the idea of note sharing. So I want to be clear, we're 100% foundation focused, and this is in no way a sales pitch for any kind of product beyond transparency with patients. I'm going to start off today as kind of an icebreaker with a quick video. So this video comes from pre-HIPAA days, and it may have some people that that are familiar to you. So I love that Seinfeld episode. It's called The Difficult Patient. It's on YouTube if you're interested in having a trip down memory lane to the 1990s. Oh, I went too far. So I wanted to take a minute just to do a little definitional work to make sure that I'm being totally clear about what I'm talking about. So notes, just generally, they're written by doctors, nurses, therapists, other healthcare providers, and they describe the interaction with the patient. So when you go to see a clinician, they write a note about that interaction that they had with you. OpenNotes are usually visit notes that patients can easily read. They're often available through the patient portal. Sometimes clinicians will print them out and give them to patients, but generally they're available through the portal. And then OpenNotes, with capital letters, so this is how we distinguish it, is an international movement that's supporting the adoption of OpenNotes. So there's a lot of notes and open thrown in there, so I just wanted to make sure that I was clear on what we were talking about. So let's just take a little bit of a closer look at notes. They have a lot of names. Sometimes they're called visit notes, sometimes they're called clinic notes or progress notes, chart notes. Sometimes they're called SOAP notes, so subjective, objective, assessment, and plan. So they're called a lot of different things, but they're all, again, that first definition. These are notes about the interaction between the clinician and the patient. They're part of the medical record, just like test results, medication lists, or x-ray reports. They're about the patient. So the note is about the patient. It's the patient's information. Being able to read it is not a privilege. It's a right guaranteed by HIPAA. It may actually be the simplest piece of HIPAA and the most frequently forgotten piece of HIPAA. So most of us, when we think of HIPAA, it's the forms that we sign when we go to the clinician's office. But another important piece of HIPAA is that it guaranteed patients the right to their medical record. And they can look very different depending on who writes them. So when OpenNotes began, it began as a pilot study in 3 organizations, the Beth Israel Deaconess, which is in Boston, Geisinger Health System, which serves a rural population in Pennsylvania, and Harborview Medical Center. Harborview is a safety net hospital in Seattle. So what happened is they got some volunteer clinicians. They had about 100 clinicians and about 20,000 patients, and they just turned on OpenNotes. So any note that the primary care physician wrote was released to the online portal, and the patient was sent a reminder that said, you have a new note, you might want to take a look at it. So just like you can probably see you might be able to see some test results, or you might be able to request an appointment in an online portal, these patients could also read their clinical notes. Patients loved this. 85% of them read a note. 99% said they wanted the intervention to continue. And 85% of them said that the availability of OpenNotes would affect their choice of provider in the future. So once they got this information, they did not want to go back to not having it. Now, we also surveyed the physicians, and we did this before the intervention started, and then we did it post-intervention. I'm going to show you some data here. So the numbers on the left-hand side, these are from the pre-intervention survey of primary care physicians, and the numbers on the right-hand side are from the post-intervention survey. So what did we learn from these provider surveys? Well, first we learned that providers were really, really nervous, primary care providers, before the intervention started. They thought that it would make their visits take a lot longer. They thought they'd spend more time addressing patient questions outside of visits. And a lot of them thought they'd spend more time writing clinical notes. So they were quite worried. We turned it on, and you can see that those worries really didn't come to fruition. Very few reported that their visits were taking longer. Very few said that they were spending more time addressing questions outside of visits. And about 1 in 5 did say that they were spending more time writing notes. So we did a little bit of qualitative work to figure out what was going on there. And a lot of people said, well, those people should be spending more time writing notes. They're poor documenters, and they needed to do a better job. So having another set of eyes on their notes actually improved the quality of their documentation. So it was really, in the pilot sites for the clinicians, it was really a non-event. They did not notice, they didn't notice increased problems. And for the patients, they really loved it. So that's the pilot that we did in the 3 places. So 5 years later, OpenNotes is now an international movement dedicated to making transparency the standard of care. We continue to research on the effects of OpenNotes. We're looking right now at how does it affect communication with patients? How does it affect patient engagement? We have some work on safety, on patient safety. We are very interested in looking at costs and at overall quality of care. And recently have started expanding OpenNotes beyond the primary care setting and into mental health notes. So we have some pilots going on where mental health clinicians are opening their notes to patients. And in fact, the VA does that for all of their notes. And expanding into other areas like inpatient notes. We've had some requests recently around inpatient notes. So those are new areas for us. And since the study was done, where we had about 20,000 patients in 2010, we now have filled in, we're really starting to fill in the map. OpenNotes is spreading, and it's spreading pretty quickly. In fact, since I sent this slide, so the video that had of the difficult patient said 10,000 patients, so we made that video last fall. I sent this slide in last week with 13 million patients with access to OpenNotes, and as of late last week, we're now up to 14 million patients. So OpenNotes is kind of taking on a life of its own. That includes the state of Wisconsin. There are about 7 places in Wisconsin that are doing it, and 5 more that we know of that have told us that they're interested in implementing in the next year. So what have we learned from these 80+ implementations? OpenNotes, reading the notes, really has a very positive effect on patient engagement. So we know that patients remember about half of what they learn, what they hear in a physician office during clinical encounter. We know that that proportion goes down when the situation is stressful. So the more stressful the encounter, the less the patient remembers. So the note helps to reinforce a clinical message because it's right there. The patient can go back to it when they're at home, maybe they're with a family member, and they can read through it and say, oh yeah, this is what I'm supposed to, this is what we talked about. And it helps to solve the problem of, I have no idea what the doctor said. I went to the doctor, what did the doctor say? Nothing, everything's fine. So it helps with that problem. We're finding it helps patients to contribute to safety monitoring. So it's not just the clinician's eyes that are on the note, it's the patient's eyes. We have a pilot going on at the Beth Israel Deaconess and at Children's Hospital where we've asked patients to comment on the note after they read it, and about a third of them identify a safety error in their note. And about half of those errors are deemed to be clinically significant by a review team, and they need to be fixed in the note. So for example, things like at Children's Hospital, the note was written in the wrong twins chart. That's an example that comes up. That came up more than once in the study. Other things like a medication was wrong, a description of the symptoms was wrong, or a description of the care plan was not correct. So patients are very good at identifying when there's a problem with their chart. Now, they're also quite good at knowing, well, this is something like my name's spelled wrong or my wife's name is wrong in the note, but I'm not going to bother the physician with that. So they're differentiating. So they're not just calling about every problem that they find in the note. Patients are quite resourceful and able to differentiate. It increases trust, and it really helps to strengthen the patient-clinician relationship. And we see this even among patients who say, I didn't understand what that note was about, or I don't speak enough English to understand, to read the note myself, or I didn't read the note. But they still say that the openness makes them feel more trusting in their provider. And it's something about the offer of the note that creates this relational benefit with the patient. And we know that a strengthened relationship between a patient and a clinician has a lot of downstream effects for positive outcomes. Patients tell us it helps them to be better prepared for their visits. They go back and they read the note before the next visit, and so they have their list of questions, or they have a couple of things they want to be sure that they follow up on with the provider. So it helps them to be prepared for their visit, and it helps them to understand a clinical rationale. Sometimes, with that 50%, remembering about 50% of what you hear in a doctor's office, you might remember, oh, I'm supposed to do this, but I don't remember why I'm supposed to do this. So it helps helps patients understand the why. Now, we don't know everything. I mean, this is a fairly new and rapidly growing change. It is, and I want to just stress that it's relatively simple to turn OpenNotes on. In most major electronic health record systems, there's a little bit of programming involved, but it's not a major technology lift. But what it is a major culture change. Clinicians and healthcare organizations have to come to the idea that the notes belong to the patient, that the patient can benefit from the note, and that the patient has a right to the note. So all of those things are a big change for healthcare, and we don't really know yet what all of the effects are. I mean, we think it might bolster adherence, and we have some data that suggests that it does help patients take their medications better. So we have some from a small study at Geisinger that shows that patients on antihypertensives do a better job taking their medications. But we also have patients telling us they do a better job. In the pilot, 75% of patients said they did a better job managing their meds. Now, we know that medication adherence is a giant problem. So even if that's a 5-fold overestimation, it's still pretty great that you would get better adherence in that way, even if it's a massive exaggeration. We think it might diminish redundant test ordering. I have patients tell me that they will go from they go to their regular physician, they have a test done, and then they go to the specialist, and the specialist is ready to redo the test. They will pull their note right up on their phone and say, no, look, I already had that done right here. So whether that's happening, I mean, we only know that anecdotally. Whether that's happening in a broader way, we don't know yet. We think it can help identify mistakes. The pilot work that we're doing needs to be replicated in other places, but we think that there's value there. It may affect missed appointments and visit rates. If you have better recall, if the patient has better recall, and the patient is using the note to remind themselves of what they're supposed to do, it may help with that. And it may also help moving some primary care out of the office and into the home, because the note is another way, if this bidirectional communication, the note is another way of the patient having the information in their hands when they need it at a convenient time for them. So I think I've talked for about 15 minutes. It might have been a little bit over, but I'm happy to take any questions that people have.
Thanks, Cait. So I'm curious to know, you mentioned that there were a number of systems in Wisconsin that had committed or were online maybe even. Can you talk a little about what's happening in Illinois and Iowa as well?
Sure, I can try to do that. I'm not unfortunately our Master of Dissemination, John Santa, is on a walking tour of England this month, so he's not here to talk with us. But let me just go back to the map. So the darker colored states are the ones where there's more than one organization. The lighter colored states are where there is at least one, and then the gray states are where there's only the VA. So you can see that there is activity going on in this whole region of the country. So in Minnesota, for example, we know that Sanford Health has gone to OpenNotes. So that's an enormous provider that has sites in Minnesota. And we also know that there are places in Iowa that are doing it as well. But there's a lot of activity going on in this part of the country right now.
And can you talk a little bit about you mentioned the cultural change, which I can
Yes.
only imagine. What is the cost, either in direct costs
Sure.
or the staff time that it might take to get this up and running and then maintain it?
Sure. So I can tell you a little, just a quick story. Most of the places that have done this up until now have done it for no money. They just decided it was the right thing to do, and they did it. The New York State Health Foundation is now giving organizations $100,000 to do it. I don't think it costs $100,000. The cost is relatively low because the technology is already in place in most EHRs. It's a very small lift in terms of the technology cost. The costs are really related to, you need a champion. You need champions, you probably need more than one champion, and you probably need them in several different departments. And they need to go to their colleagues. They need to go to senior leadership and go to their colleagues and talk about why this is the right thing to do. So that's the primary cost, is just the time that it takes for the champions. And then there's a small cost related to if you want to have materials prepared for patients, or waiting room posters or other kinds of materials available for patients, then there is a cost there. Now, we have developed a lot of that already, and we're happy to help in any way. So we have materials on our website that people can just use. That's the primary cost.
Good, thank you.
Before about the instance of a patient seeing a specialist and having access to OpenNotes on their phone and the specialist ordering a test and then having the patient pull it up. I'm wondering about the interoperability of the OpenNotes across systems, since some systems have opt-in,
Right.
some don't.
Right. So the way that OpenNotes works is you're right, some places it's an opt-in method. So individual clinicians have to decide to share the note on the portal. I think that that's suboptimal. First of all, it's an extra click for a physician. They already hate their EHR, and they don't want to do anything else. They don't want to interact any more with the EHR than they absolutely have to. So the opt-in method tends to lead to pretty low rates of note sharing. Other places do an opt-out, where a clinician has to actively say, I don't want to do this. And again, clinicians are very busy, so taking the extra step to do it, they have to be pretty committed. They have to really hate the idea to want to go through the process of opting out. I do want to mention that all of the EHR systems that can do this offer an option for a clinician to hide a note. So if they feel like there's really a safety concern, say for example, a domestic violence situation, they may want to hide a note. And so there's always that option. The rates of note hiding are fairly low, though, they're around 3%. Now, just one more thought about interoperability. I think of OpenNotes as a way for the patient to be the interoperable factor in the healthcare system. So if they can log on to their notes, let's say they get their care from Elina and they can log in and get their notes, and then they go to another provider that doesn't use it yet, they're still carrying their information with them. So I think of OpenNotes as a way of getting around the interoperability issue.
One more question, and then we'll move into the panel part of the discussion. Cait, I thought I heard in the video e-patient Dave talk about being able to see the notes for your children or your parents. How do patients feel about letting other people see their notes? I'm channeling myself as a 16-year-old, thinking if my mother could see all of my notes, I wasn't concerned about healthcare, more my diary, but nevertheless, TMI perhaps. I'm just thinking about if there are patient privacy concerns that you've run into.
Sure. So adolescents come up all the time as a patient privacy issue, and the laws vary by states, but most places do a lot of different things around adolescent access to the EHR portal in general, even with or without notes. Some places cut adolescents off at 13. Some places create proxy accounts so the parents can see some information and not other pieces of information. And a lot of places will use a confidential note as well. So state law requires that certain conversations between adolescents and clinicians are confidential, so there's a confidential note that they can write, and they'll just say to the patient, this isn't going to show up in the portal. I think of this as a particularly valuable tool for caregivers, and most EHRs allow the creation of a proxy account. So I'm a proxy, for example, for my aunt, so I can see all of her information. It really does help with hey, you went to the doctor today, how'd it go? And they say, oh, fine. What did the doctor say? Nothing. So it really helps with that kind of a problem. But it's always the patient's choice to provide the access to the caregiver. In order for these proxies to be set up, the patient has to agree to it. So it's always within the patient's realm of control.